We're joined by Dr. Rowan Chlebowski, Professor of Medicine at the David Geffen School of Medicine at UCLA and Chief of Medical Oncology and Hematology at Harbor-UCLA Medical Center. He is also one of the lead investigators for the Women's Health Initiative. Thank you for joining us.
Happy to be here.
The Women's Health Initiative findings about hormone therapy caused an end to the studies with estrogen and estrogen plus progestin. As you continue to review the data, would you discuss information on menopausal hormone therapy's influence on cancer incidence and related cancer mortality?
Sure, and a little bit of a background. Conjugated equine estrogens were introduced in practice in the United States in 1942. When the study started in 1993, they were being used by over 40% of postmenopausal women, but had never been tested in a prospective randomized trial. So the Women's Health Initiative, beginning in 1993, did that with two different preparations. One was conjugated equine estrogen plus medroxyprogesterone acetate, that was kind of Prempro, which was used for women with a uterus because they needed the progesterone to protect against endometrial proliferation and cancer. And a second separate study in women who had a prior hysterectomy for some kind of medical reason, and they were given randomized to placebo or conjugated equine estrogen or Premarin alone. And so those studies, we'll talk about the estrogen plus progestin combined hormone therapy trial first. The study was stopped after about 5.6 years of intervention when surprisingly more harm than benefit was identified. And the harms included an increase in coronary heart disease, stroke, pulmonary embolus, and invasive breast cancer. And we have subsequently followed the patients after stopping therapy. I think one of the surprising findings were the breast cancer findings right off the bat. Observational studies had suggested breast cancer might be increased, but that the cancers would be favorable and low grade and mostly ER positive. But in fact, we found the cancers were actually a more advanced stage, and all varieties of cancer were increased. And the reason for that was that estrogen plus progestin interfered with breast cancer diagnosis, with mammographic performance, and even performance of biopsies. So those, and we've just recently updated these findings in the Journal of the American Medical Association earlier this year and demonstrated increase in deaths from breast cancer as well. So that's one part of the cancer story. The other part was that we had shown reported a 44% lower incidence of colorectal cancer, which sounds like a very favorable finding, yet those cancers were diagnosed at substantially higher stage. About 80% were regional or metastatic compared to under 50% for patients who developed colorectal cancers on placebo. And very surprisingly, that now there are numerically more deaths from colorectal cancer in the estrogen plus progestin group, so hardly a favorable outcome. Then we also showed that there was about a 60% increase in ovarian cancer. It was borderline statistically significant because there's very few events, but this is probably the best evidence that ovarian cancer is increased. Finally, when we saw after we stopped the study was that there was an increase in all categories of malignancy. And in investigating that further, we looked at lung cancer. And what we found was very surprising. So the incidence of lung cancer, all kinds, was about 23% higher on the estrogen plus progestin. That wasn't statistically significant, but breast cancer mortality was 70% greater. And it was pretty much all in non-small cell lung cancer mortality, where deaths from non-small cell lung cancer were nearly doubled. And this was especially seen in current or past smokers, but it represented very high risk. So in about 15% of women, postmenopausal women in the United States are current smokers, and about 35% are past smokers. If a woman was a current smoker, used estrogen plus progestin for about 5.5 years, 1 in 100 had an otherwise avoidable death from lung cancer. And if they were past smokers, 1 in 200 had an otherwise avoidable death from lung cancer. So that's not incidence, that's actually being dead. So, those findings really should be integrated now into risk-benefit decision-making. I think just in the last year, it really reinforces the concept that lowest dose, shortest duration, and that women should only be taking them for climacteric symptoms and only if they find the symptoms kind of limiting. So that's the kind of estrogen plus progestin side of it. On estrogen alone, the story was really quite different. The study went longer, but still was stopped early after 7.1 years. It was stopped because there was no overall net harm, but it was unlikely to show a benefit either, so it stopped for futility in terms of showing a difference. At that time, there were about 20% fewer invasive breast cancers on the estrogen alone group, and some subgroups had significantly less breast cancer. But the interesting finding there is when we looked at the time from menopause to when the cancers developed, women who who started hormone therapy more than 5 years from menopause were the ones who had a lower breast cancer incidence. Women who started within 5 years of menopause, which would be the usual clinical approach for development of menopausal symptoms, they really had no evidence of lower breast cancer incidence with a hazard ratio of 1.06. None of the other cancer detrimental effects were seen. There was no effect on colorectal cancer, even though some observational studies had suggested estrogen alone might reduce colorectal cancer. There was no increase in lung cancers or death from lung cancers.
You found that women who received bisphosphonates for osteoporosis had a 32% relative reduction in the overall risk of breast cancer compared with those that did not receive bisphosphonates. And when we last spoke, you talked about potential synergies, and now we're seeing some negative findings from the Azure trial with zoledronic acid. I'd love to get your thoughts on this.
Yeah, so that's a very long-standing issue, actually. You know, it started in probably in 1998 when the first report of an adjuvant trial with women with metastases just to the bone marrow, otherwise localized disease, were randomized to clodronate or not, and they had fewer recurrences. Trevor Powell showed the same thing in a survival benefit that was maintained in pre- and postmenopausal women who received clodronate as a sole treatment variable. Another study about the same size of 400 as the first deal study didn't show a favorable benefit, but that had an imbalance in terms of treatment, and so it's kind of a discredited study. Then we had about 2 years ago now, Michael Gannett from ABCSG 12 published a report where this was premenopausal women, full-scale adjuvant trial, given glycerin to make them in the postmenopausal estrogen range, and then hormone therapy with tamoxifen or anastrozole with or without zoledronic acid at a very low dose of 4 milligrams every 6 months. And we're used to treating patients with skeletal-related events that 4 milligram dose every month or every 28 days. So this is a much reduced dose. Interestingly, they saw about 30% fewer metastases in the zoledronic acid group versus the placebo group. And it wasn't just bony metastases, it was local regional disease as well. And so that really sparked interest into that whole question. So I went back to the Women's Health Initiative overall population, which was 154,000 postmenopausal women. They were entered on a variety of clinical trials and observational study. So we looked at medication use in that population, and we compared the bisphosphonate users to the non-bisphosphonate users. We had to make an adjustment for bone mineral density difference because women get bisphosphonates because they have low bone mineral density or osteoporosis or osteopenia, and low bone mineral density has been shown to be strongly associated with breast cancer risk. But we were able to do that because we had 10,000 women who had bone mineral density done, and we had developed and validated this 7-item questionnaire which gave us a model for predicting hip fracture risk in all the 154,000 women. So in the 10,000 women, we looked at the hip fracture prediction against the bone mineral density, saw a strong correlation, so could use the bone mineral density, the hip fractures predictive score, which we had on everybody, to correct for bone mineral density. And when we did, we saw 32% fewer breast cancers in bisphosphonate users. It looked like it was both ER positive and ER negative cancers. At that same ASCO meeting, and now published both together in the Journal of Clinical Oncology, a population in Israel, a case control population, not a cohort, showed similar findings. And also there's been another case control study from a Wisconsin case control study that also saw almost identical findings. So this is very strong background. And people were and the ABCSG 12 data was used for an application for FDA label indication for adjuvant therapy, which is pending from the FDA. And that would have been for premenopausal women receiving hormone therapy, where they would get this 4 milligram every 6-month dose. Well, in the meantime, another study had been ongoing, this Azure study, which is 3,300 women, which were pre- and postmenopausal, very similar to the Trevor Powell study, giving chemotherapy or not, though over 90% received chemotherapy, and hormone therapy or not. And all the rest of the therapy was at physician's discretion, and the sole treatment variable was zoledronic acid, but in a more intensive dose. So they had 6 cycles every month, and then 8 cycles every 3 months, and finished out to 5 years. The prior ABCSG 12 trial only went out to 3 years. Well, and everybody was anticipating a positive result, and what we saw right at this meeting was that the hazard ratio was 0.97, so that is really a kind of negative report. When they looked at the premenopausal women, which might be more comparable perhaps to the ABCSG12 population, that wasn't any better. And so subsequent subgroup analyses, which are certainly exploratory and hypothesis generated, identified if women were entered 5 years from menopause and postmenopausal, then they had this a hazard ratio of 0.63, so 37% fewer breast cancers. And so the hypothesis is that, well, maybe you need low estrogen for bisphosphonates to be effective. That's kind of a new hypothesis, but that doesn't help the overall kind of standing, of the position. So, so we're left with that. I mean, there's biological plausibility for this 5-year period because estrogen is going down even after women stop menstruation for about 5 years. And we had shown in the Women's Health Initiative for estrogen alone, just as we said, that it took this interval and made a difference in whether estrogen reduced breast cancer incidence or not. So the study is left with a big negative finding, a new hypothesis, but very difficult to come back from that. You run 2 trials and you get 2 opposite results. There are other studies that are ongoing. There's another bisphosphonate, abandonate or not, is in a clinical trial, and this kind of provides a problem for a United States trial because the United States cooperative group study, which has been going on for years, it has taken patients with resected early stage breast cancer, randomizes them to clodronate, one of the drugs used in earlier studies, zoledronic acid, and abandonate. But of course, now that zoledronic acid didn't work, we're left pretty much without a control population, right? And so that's continuing to follow an old, NSABP trial that's been going for a long time with relatively early stage patients is continuing to track a clodronate versus not trial. When you look at the ABCSG12 trial compared to the Azure trial, they, in retrospect, they are different because there was no chemotherapy in the ABCSG12, 90% in the Azure trial. Nobody ended up having estrogen suppression except low estrogen, except that subset that was looked at in the Azure trial. So there, and the Azure trial was high risk, multiple node positive, which was relatively low risk in the ABCSG12 study. But we are really, there were 2 breast cancer populations left with 2 different kind of results. So we're waiting for these other 3 studies to go forward. But the hope that we would end up having an adjuvant bisphosphonate zoledronic acid indication, days or weeks after this meeting, with the result would support the other findings. It's just not there.
Well, while I have you, I want to ask you about your feelings overall, though, on the progress of this field.
Well, let's see. I guess, yeah. So it really has to be viewed as a setback because you really have to end up. You had all this accumulating data leading up to this, then you have this disappointing result, and now you have to wait for 3 more studies to come forward, and then try to sort those out. And of course, what would you do if zoledronic acid won in the comparative trial against 2 other agents, but with no control? So we have not very exciting prospects, kind of in that area.
Well, Dr. Chlebowski, thank you so much.
Okay, you're more than welcome.